Okay, sir. Okay, sir. Shall I proceed, sir? Hmm. So, good morning to all my dear students. So, myself, Dr. Nagarjuna. Yesterday itself, I given my introduction. So, for the newcomers and the new entries, I'm telling myself, Dr. Nagarjuna, Pharmacology faculty. I'm the coordinator for GPAT cell in Raipur, Anantapur. I'm the coordinator for Hyderabad Academy and online GPAT Academy. So, these are the academies providing coaching for students in GPAT since from last 10 to 12 years. So, on this platform, once again, I would like to thank the government of Andhra Pradesh, JNTU Anantapur and JNTU Kakinada for providing this wonderful platform to all the students. Anyway, yesterday we discussed about pharmacodynamics. So regarding the receptors, types of receptors, mechanism of action, everything and all in detail. The continuation of these pharmacology topics. Today I would like to discuss about a topic called as drugs acting on GIT. So what is this? Drugs acting on GIT. It's a very simple topic, easy you can understand. So for this, we'll see one by one. So today's our topic is drugs acting on gastrointestinal tract. See one by one. So we'll go with the basics to advances. The first, here you have to understand the two terminologies. One is diseases, another one is disorders. I think we are very commonly using these two words, diseases and disorders. So what exactly mean by these conditions is diseases are caused by pathogenic or harmful microorganisms like tuberculosis, leprosy, typhoid, malaria. Disorders means which are due to abnormal or altered functioning of any body system. See, our human body is made up of several systems. Every system in our body has certain function. When the function of the system gets altered, becomes abnormal, those conditions are called as disorders. Examples are diabetes mellitus, peptic ulcer, hypertension, hypotension, hyperthyroidism, and hypothyroidism. So, mean to say, if you see here, everyone is having normal blood pressure. But the altered, increased or decreased blood pressure is called as disorder. Everyone is having glucose in the blood. But excessive glucose levels in the blood is called as diabetes mellitus. Everyone is having acid secretion. But excessive acid secretion is called as peptic ulcer. So what you have to understand is the disorders means the function becomes more or the function becomes less. So those type of conditions are called as disorders. See here, the whatever the conditions resulted because of the pathogenic harmful microorganisms are called as diseases, which are due to abnormal or altered functioning of body system are called as disorders. So mean to say that every human being is having glucose in the blood. Excessive glucose levels in the blood is called as diabetes. Everyone is having blood pressure, normal blood pressure. The excess blood pressure, decreased blood pressure called as disorders called as hypertension and hypotension. In the same way, every human being is having acid secretion, the normal acid secretion. The excessive acid secretion is called as peptic ulcer. So that is the way you have to understand the difference between diseases and disorders. And if you come into here, there are three words you have to see. What is this? One is physiology, another is pathophysiology, another is pharmacology. These are all the three branches actually you should know. So what is physiology is study of normal functioning of body systems. Pathophysiology means study of disorders. Pharmacology means study of drugs. So try to understand. I think you have seen your curriculum, the 3 subjects, 3 branches. So physiology means study of normal functioning of body systems. Pathophysiology means study of disorders. Pharmacology means study of drugs. Just now I told you all the drugs are used for the treatment of disorders, drugs acting on different systems. So if you want to understand about the drugs, we should know about the disorders, means pathophysiology. So if you want to understand about the disorders, you should know about the normal functioning, nothing but your physiology. So that's why if you see in your first year curriculum, you have a subject called as physiology. In your second year, you have a pathophysiology. In the third year, you have a pharmacology. So this is the link. If you understand physiology, you can easily understand about pathophysiology. If you understand this pathophysiology, you can understand this pharmacology. So now we'll move on to this. Same. To understand about the drugs acting on GIT, first we'll move on to the physiology. I mean, basically, not in detail. So basic what you can say is brief revision of the normal functioning as well as the disorders. So first we'll move on to the major parts of GIT. I'm not going in detail. Just at peripheral, I will explain what is the normal function, what are the disorders, then we'll move on to the drugs under. So if you see the major parts of GIT include, we all know that stomach, small intestine, large intestine. Am I right? These are 3 major parts of GIT. So if you come into the function, we all know that the stomach is the organ involved in the secretion of acid or HCl. We all know that, right? The stomach is involved in the secretion of acid or HCl. So what is the function of this acid is? For the process of digestion. So what is digestion? The breakdown of large particles into small particles. As well as the acid is helpful to kill the microorganisms. Am I right? The acid has the 2 major functions. One is involved in the process of digestion, so decrease in particle size, and another function is to kill the microorganisms. So whatever the microorganisms which are entering through GIT, through oral cavity, all those microorganisms are killed by the acid. Second is small intestine. So small intestine is the area for absorption where the food as well as majority of drugs will undergo absorption. The meaning of absorption is entry into systemic circulation, entry into blood. And third one is large intestine. Small intestine is the area for absorption where all digested food as well as drugs will undergo absorption. So absorption means enter into systemic circulation, enter into blood. So large intestine, so where all unabsorbed substances, which are not absorbed, I'm saying, all unabsorbed substances are eliminated through the stools or the fecal matter, and this process called as defecation. So we all know that the all unabsorbed. Unabsorbed means which not entered into blood. All waste substances are eliminated through stools or fecal matter, and the elimination through stools fecal matter called as defecation. Am I right? So each and every part of the GIT has its own major functions. Stomach is the area for digestion. Small intestine is the area for absorption. Large intestine is the area for elimination. So coming to the small intestine, why it is the area for absorption? Why most of the drugs? Why the digested food mostly undergo absorption from small intestine is because of these reasons. I think we have all studied in the biopharmaceutics and in pharmacology what is the criteria for absorption. So we all know that the absorption requires less particle size. Absorption requires large surface area. Absorption requires an ionized form. How will you get all these things in small intestine is, what type of things will reach to small intestine? The things from stomach, it will reach to small intestine. So already in the stomach, it will undergo digestion. So means all digested compounds will reach small intestine. So as a result, particle size will be decreases. So digested compounds will reach small intestine. So that's why we are telling digestion is very much essential for the process of absorption. If more digestion is there, more decrease in the size, you will get more absorption. That is the reason why we should not swallow the food. We should chew the food. We should masticate the food. If you chew the food more times in your mouth, the more decrease in particle size, you will get more absorption. And then large surface area is required for absorption. In the small intestine, we have villi and microvilli, which will offer very large surface area that is more convenient for the process of absorption. Next is lipophilicity. So we should take the drugs in lipophilic and non-polar form for getting better absorption. Next is unionized form. A drug to be absorbed, the drug should be present in unionized form. This ionization, we know that depends upon the pH. Always opposite environment will favor ionization. Same environment will favor unionization. If you see our pharmaceutical drugs, mostly are weak acids to weak bases. So most of our pharmaceutical drugs are weak acids to weak bases. And even if you see small intestine, in the small intestine we have a pH in between weak acidic to weak basic. So that's why all of our drugs existed in unionized form in the small intestine, and which is suitable for the process of absorption. So you please try to understand. So most of our pharmaceutical drugs are the small intestine will have a pH. So most of our pharmaceutical drugs are either weak acids or weak bases. And in the small intestine, we have weak acidic to weak basic pH. So because of the same environment, because of the same pH, most of the drugs exist in unionized form in the small intestine, and which is suitable for the process of absorption. So I'm repeating, the small intestine is the most convenient area for absorption because of these reasons. The one is less particle size. Means after the digestion, the components will reach the small intestine, because from the stomach, the compounds will come to small intestine. Next, large surface area. This is done by villi and microvilli present in small intestine. Then all the drugs will exist in unionized form in small intestine, because most of our drugs are weak acids to weak bases, and in the small intestine pH is also in between weak acidic to weak basic. So coming to the disorders, just now I told you physiology first. This is the link, right? Physiology is study of normal functioning, pathophysiology is study of disorders, pharmacology is study of drugs. So physiology, just now I told, very briefly I'm telling once again. Stomach is site for digestion, small intestine is for absorption, large intestine is for elimination. Digestion means breakdown process, absorption means entry into systemic circulation, entry into blood. Elimination means all unabsorbed waste substances are eliminated through stools, fecal matter, called as defecation. So this is the basic functioning of GAD. The next is what? After basic functioning, disorders. So what are the disorders will come to the GAT? You see here, same thing. We told stomach is normal function secretion of acid. The excessive acid secretion called as peptic ulcer. The decreased or absence of acid secretion called as echlorhydria. Same, the large intestine is the area for elimination through stools. Excessive passage of stools called as diarrhea. Decreased passage of stools called as constipation. And another disorder related to GIT is emesis, vomiting. Clear? So these are all the disorders of GIT. So peptic ulcer, excessive secretion of acid. Echlorhydria, in the medical terminology, A stands for absence. Absence of acid secretion or decrease in acid secretion called as echlorhydria. Vomiting is called as emesis. Excessive passage of stools called as diarrhea. decreased passage of stool is called as constipation. In the same way, we move on to the drugs acting on GIT. On the same basis, what are the drugs will act on GIT? Same thing. First disorder is peptic ulcer. The first class of drugs is anti-ulcer drugs. Next is drugs for achlorhydria, emetics and antiemetics, antidiarrheal agents. Then drugs for constipation, which are called as laxatives. So got it now? This is the way to understand and you have to start. So always you should not open your textbooks directly and you should not read. See, always you should not open your textbooks directly and you should not go for directly class. So always I'm telling that drugs acting on any system indicating that those are for the treatment of disorders. So what is the sequence is? First, what is the physiology? What is the normal functioning of the system? Next is pathophysiology. We have to study about disorders, mean at least some basic understanding. What is the name of the disorder? What is happening in the disorder? What is the reason for the disorder? Then we should move on the drugs. Same thing, what is the normal function of GIT? Disorders of GIT, drugs acting on GIT. Now we will see one by one in detail. First, we'll move on to the anti-ulcer drugs. So we all know that anti-ulcer drugs means which are used for the treatment of peptic ulcer. So what is peptic ulcer is? Peptic ulcer is characterized by the excessive secretion of acid. The excessive secretion of acid is called as acidity. Clear? So everyone is having secretion of acid that I told you. The excessive secretion of acid is called as acidity. If the acidity is there for long period of time, that lead to the formation of some wounds, injuries, which are called as ulcers. Got my point? I told you just now, the normal function is release of acid, secretion of acid. The excessive secretion of acid is called as acidity. If the acidity is there for long period of time for any person, that leads to formation of some injuries in the parts of GIT which are called as ulcers. So where the ulcers take place? The ulcers take place in the areas which are highly exposed to acid. Am I right? If you see our GIT, gastrointestinal tract, so which areas are highly exposed to acid? Is we know that where the acid is secreted, acid is secreted from stomach. So that stomach is highly exposed to acid. Then next to the stomach, which is highly exposed, what is the next part of stomach? Small intestine. In the small intestine, what is the first part? Duodenum. Small intestine will have first part duodenum, next jejunum, next ileum. So which are highly exposed to acid? Stomach and duodenum are highly exposed to acid. Henceforth, the ulcers take place either in the stomach or in the duodenum. So usually peptic ulcer is of two types based upon the location. The ulcers in the stomach called as gastric ulcers and the ulcers in the duodenum called as duodenal ulcers. So got it now. Ulcers in the stomach called as gastric ulcers and ulcers in the duodenum called as duodenal ulcers. Let us see here the same thing. The represented the formation of ulcers in the parts of GIT. See here, this is a normal stomach. See here, some wounds, lesions, erosions take place in the stomach, which are called as stomach ulcers, gastric ulcers. The ulcers are wounds in the duodenum, which are called as duodenal ulcers. Actually, what is the reason for these ulcers? Not only for the ulcers, for any disorders I'm speaking here. For that, we should know the word called as homeostasis. This is very important. For this, we should know the word called as homeostasis. The meaning of homeostasis is the maintenance of balance, the maintenance of equilibrium inside the body called as homeostasis. Clear? Try to understand. The maintenance of balance, the maintenance of equilibrium inside the body called as homeostasis. As long as homeostasis is maintained, the individual cannot develop any disorders. The individual cannot develop any disorders. So I told you very commonly so many times, disorder means altered function. The reason for altered function is disturbance in the homeostasis. So I mean to say that our body is made up of several systems which are contributing for the process of homeostasis balance inside the body. So when the homeostasis is disturbed, that lead to the disorders. So what is the example for homeostasis? So many things, right? So maintenance of acid secretion, maintenance of blood glucose, maintenance of blood pressure, maintenance of pulse rate, maintenance of body temperature, maintenance of fluid and electrolyte balance. This is all called as homeostasis. And our body is having several systems which will mutually adjust themselves and they will maintain the balance, they will maintain the homeostasis. So as long as you have a homeostasis, the individual cannot develop any disorders. But when the disorders will come, when there is a disturbance in the homeostasis. So the thing is, if you see insulin decreases blood glucose levels. Glucagon increases blood glucose levels. So both insulin and glucagon should be in the balance. That is a homeostasis. So the person can maintain normal blood glucose levels. So whenever homeostasis is disturbed, insulin decreases, deficiency of insulin, that leads to diabetes. So likewise, I'm telling that for every disorder, that may be diabetes, hypertension, thyroidism, ulcers, or whatnot. For every disorder, the reason is disturbance in the homeostasis. So our duty is where that homeostasis was disturbed. So where it is increased and where it is decreased. That is very important. Our present topic is what? Ulcer. So dealing with the excessive acid secretion. First, we have to know what is the homeostasis for acid secretion. Am I right? So one of the homeostasis is maintenance of acid secretion. So acid secretion is well maintained by two factors in our body. One is called as aggressive factors, another is called as defensive factors. Acid secretion is well maintained by two factors in our body. So one is aggressive factors, another is defensive factors. The aggressive factors mean the factors which increase the acid secretion. The defensive factors means the factors which decrease the acid secretion. Both should be in the balance, both should be in the equal, usually. This is how the acid secretion is maintained in our body. So the examples of aggressive factors are acetylcholine, histamine, gastrin. The examples of defensive factors, mucus, bicarbonate ions, prostaglandins. As you all know that mucus is responsible for protection of layers of GAT from direct exposure to acid. We know that the role of bicarbonate ions is neutralization of acid. So which are aggressive factors, which are defensive factors, which increase acid secretion, which decrease acid secretion, both should be in the balance. Then acid secretion is maintained, that is called as homeostasis. Now, when the ulcers come, when the disorders come, the disorder comes when there is a disturbance in the homeostasis. How this homeostasis is disturbed? See here, disturbance in the homeostasis. So how this homeostasis is disturbed is because of either increase in aggressive factors or decrease in defensive factors. Am I right? Because of increase in aggressive factors or because of decrease in defensive factors. So means the increase in aggressive factors like maybe increase levels of acetylcholine or increase levels of histamine, increase levels of gastrin, And very few cases, ulcers also occur because of a disease, contamination with microorganism called as Helicobacter pylori. So usually it is a disorder. Sometimes it is a disease caused by the contamination with microorganisms. The organism is Helicobacter pylori. And due to decreased levels of defensive factors like mucus, bicarbonate, prostaglandins. So we are feeling that ulcers occur when we take the spicy food and all. So is it correct? So whoever will take spicy food, they are getting ulcers. Suppose if you are not taking spicy food, can you show that you will not get ulcers? No. So the reason is what I'm telling. See, if you take very spicy food, immediately acid secretion will increase. But immediately our body releases defensive factors which will balance the acid secretion. The persons are doing fasting. Whenever the fasting if you do, because of the empty stomach, the more and more acid secretion will be there. Immediately the defensive factors will release that will balance the acid secretion. So means this spicy food, this fasting, these are all not at all reasons for ulcers. So as long as homeostasis is maintained, a person cannot develop ulcers, nothing will happen. So the only reason for ulcer, so I'm repeatedly telling, not only for the ulcer, the reason for every disorder altered function is disturbance in the normal function, disturbance in the homeostasis. Our duty is we have to find out which is increased and which is decreased. Yesterday itself I told you every drug in pharmacology is two types, either agonist or antagonist. So agonist means which produces actions similar to ligand. Antagonist means which will stop the or block the actions of ligand. Our duty is we have to know for which we have to use agonist, for which we have to use antagonist. So now here clearly it mentioned, so these ulcers occur due to increase in aggressive factors and decrease in defensive factors. So based on this, what we can see? For aggressive factors, we have to use antagonists, and for defensive factors, we have to use agonists. Am I right? The ulcers occur due to increase in aggressive factors or decrease in defensive factors. So that these levels are increased, so that we have to use antagonists. These factors are decreased, so that we have to use agonists. So that is the only reason I told you yesterday what is agonist and what is antagonist. Now if you see how the acid secretion takes place, also just for representation, if you consider the parietal cells, as I told you, the parietal cells are located in stomach. Their duty is release of acid. These parietal cells will release acid with the help of a proton pump. The proton pump, also called as H plus K plus ATPase, they release H plus ions, means this is C here, this is acid, in exchange with potassium ions. Parietal cells are located in stomach, which release acid with the help of the proton pump. Proton pump, otherwise called as H plus K plus ATPase, which releases H plus acid in exchange with potassium ions. How? These are all aggressive factors. I told you, acetylcholine bind to the receptors, histamine. Everyone is having its own receptors. Am I right? So which are located in the parietal cells. So what are those receptors present? Just we'll see. Yesterday itself I told you. See, H plus K plus APase, releasing H plus, exchange with potassium. So aggressive factors and defensive factors. So acetylcholine, we have receptors called as M3. Yesterday I told you M1. Actually in the parietal cells, we have both M1 as well as M3, but majorly mediated by M1. But the represented 3, okay, no problem. M1 and M3 both are present because M3 I told you smooth muscles. So parietal cells means GAT. GAT is nothing but a smooth muscle. Like that they mentioned here. H2 receptors. Gastrin is having CCK2, cholecystokinin receptors. Because gastrin is one of the kinin, cholecystokinin. These are all aggressive factors. These three will increase acid secretion by binding to their receptors, acetylcholine M1, M3, histamine H2, gastrin CCK2. And prostaglandins are defensive factors, decrease acid secretion by binding to PZE2 receptors. PZE2 receptors. So that based on this, what drugs we can use for ulcers? See, ulcers is because of disturbance in homeostasis, because of increase in aggressive factors, decrease in defensive factors. So that which drugs we have to use? For all these things, we have to use antagonists. For all these things, we have to use agonists. So antagonist means what drugs will come here? Anticholinergics, antihistamines, gastrin antagonists, antibiotics, or anti-helicobacter pylori drugs. For this, mucus biochem cannot do. So prostaglandin agonists or prostaglandin analogs. Am I right? Yes or no? For all the aggressive factors, antagonists. For all the defensive factors, agonists. So receptors also mentioned for acetylcholine M1, M3, histamine H2, gastrin CCK2. So based on this, if you see here, they mentioned the classification of anti-ulcer drugs. So first one, the drugs which reduce the acid secretion. Drugs which reduce the acid secretion. The first is, see here, as usual, antihistamines. So which receptor blockers, especially H2 receptor blockers. So those are, as you know, cimetidine, ranitidine, famotidine, loxartidine, and roxartidine. Next is what? Proton pump inhibitors. I told you, the parietal cells will release acid with the help of the proton pump. Here it is present, also called as H plus K plus ATPase. So proton pump inhibitors like omeprazole, lansoprazole, pantoprazole, rabiprazole, and esomeprazole. So next is anticholinergics, especially M1 receptor blockers like pyrenzepine, propanthelin, oxyphenonium. Prostaglandin analogs. See here for all these blockers, anti-inhibitors, anticholinergics. But for prostaglandins, because prostaglandins are defensive factors, so agonists we are using. So analogs, nothing but agonists. Prostaglandin agonists, prostaglandin analogs. They are misoprostol, N-prostil, rioprostil. These are all the drugs which reduce the excessive acid secretion. And apart from it, we have other drugs cause neutralization of gastric acid called as antacids. From the name itself, antacids means anti to the acids, opposite to the acids, basic substances. Their duty is to neutralize the gastric acid. I will tell you afterwards what are the things and all. Next is ulcer protectives. See, here these drugs will reduce the excessive acid secretion. These drugs will neutralize the acid secretion. Next, third class is ulcer protectives. Suppose, unfortunately, if any individual is having the formation of ulcers, we are going to use the drugs which protect the ulcers called as ulcer protectives. And then ulcer healing drugs. These are all the drugs which will directly heal the ulcers. So maximum our intention is to avoid the formation of ulcers. I told you ulcers will not happen immediately. Ulcers are because of long-term existence of acidity. The reason for ulcer is acidity. So first we'll try to correct the acidity by using these two. But unfortunately, if any individual is having formation of wounds, ulcers, we are going for ulcer protectives. And finally, we'll go for ulcer healing drugs. I told you rarely the ulcer is a disease caused by microbial contamination with Helicobacter pylori. Such a case, we are using the drugs called as anti-Helicobacter pylori drugs, some of the antibiotics. And coming to the individual discussion, I mean the small points. What are the important points about the drugs and all? So first class is antihistamines. So nothing but H2 receptor blockers we know. The examples are cimetidine, ranitidine, famotidine, loxartidine, roxartidine. So out of all, cimetidine is the first drug, we know that. But it is not withdrawn from the market because of anti-androgenic action. It decreases the production of androgens. So testosterone. It causes male sexual disturbances. That's why it is withdrawn from the market. So ranitidine, so which is available under the brand names like Rantac, Jantac. So we know that they are very commonly used in the market. Out of all H2 blockers, the famotidine is the most potent drug. So proton pump inhibitors, so also called as H plus, K plus, ATPase inhibitors. So proton pump inhibitors, also called as H plus, K plus, ATPase inhibitors. So if you see all the categories, out of all the drugs, these drugs are highly effective. So these drugs are highly effective because they stop the final step in acid secretion. But if you use these drugs for a long time, they decrease the release of intrinsic factor. This is essential for the absorption of B12 that results in pernicious anemia. See, proton pump inhibitors are highly effective. If you use these drugs for a long time, they decrease the release of intrinsic factor. Actually, this is essential for the absorption of B12. If you stop the release of intrinsic factor, the absorption of B12 will be impaired. That leads to anemia. Same thing, anticholinergics. I told you already, the receptors located in parietal cells are M1 and M3. So if you use non-selective anticholinergics, means which block all muscarinic receptors, M1, M2, M3, M4, M5. So we have so much of side effects like dry mouth, dry skin, dry eye. So that we are using selective M1 blockers like pyrenzepine and telenzepine. And if we come into the prostaglandin analogs, I told you prostaglandins are defensive factors, the very good factors. Their role is they always decrease the acid secretion. They increase the bicarbonate and mucus secretion. Henceforth, they are also called as cytoprotective agents. So try to understand, prostaglandins will have multiple advantages. Always prostaglandins are defensive factors. They decrease the acid secretion. They increase the bicarbonate secretion. They increase the mucus secretion. Henceforth, these agents are also called as cytoprotective agents. And these drugs are majorly used to treat the ulcers which are induced by NSAIDs. So these drugs are majorly used to treat the ulcers induced by NSAIDs. As you know that NSAIDs means non-steroidal anti-inflammatory drugs. They inhibit the enzyme called as cyclooxygenase, and they inhibit the production of prostaglandins. So that result in the ulcers. Got my point? So why, if you see the aspirin, diclofenac, aceclofenac, ibuprofen, indomethacin, all these drugs are producing ulcers as side effect. The reason behind is, as you know that NSAIDs are inhibiting the enzyme called as cyclooxygenase. These, due to inhibition of COX, they decrease the production of our prostaglandins. Prostaglandins are defensive factors. If you decrease the defensive factors, that leads to the formation of ulcers. So that the ulcers which are caused by NSAIDs are well treated by the drugs called as prostaglandin analogs. Another is gastrin antagonist. I told you gastrin is one of the aggressive factor, increases acid secretion, which is a cholecystokinin. So acts through CCK and CCKB receptors. So only one example for this category is available, that is proglumide, which is also not used because of a severe toxicity. And coming to the next, another important class of drugs, antacids. I told you just now, antacids are basic compounds, alkaline compounds. Because of their basic nature, they will simply neutralize the gastric acid. If you see, the antacids are of two types, systemic antacids and non-systemic antacids. Clearly you can understand. From the name itself, you can understand the difference. Systemic antacids means the antacids enter into systemic circulation. Non-systemic antacids means the antacids will not enter into systemic circulation. They will not enter into blood. But which are preferred is, you only understand, try to understand. And our requirement is what? To neutralize the acid in the stomach. To neutralize acid in the stomach. For that, what you require to neutralize acid in the stomach, whether you require absorption. I told absorption means entry into systemic circulation take place from the site of small intestine. But where we require action, we require in the stomach to neutralize the acid. So we don't want systemic, we don't want absorption. The problem with systemic antacids is they undergo absorption, they enter into systemic circulation. If the antacids enter into systemic circulation, what happened? They are basic compounds. So they will change the pH of blood and they produce the condition called as systemic alkalosis. Got my point? If antacids, if basic compounds will enter into blood, the blood pH becomes basic, they called as systemic alkalosis. Because of this systemic alkalosis side effect, the systemic antacids are not that much preferred. If you see non-systemic antacids, they will not enter into blood. They only produce local action. They produce action only in the stomach. The examples are aluminum salts and magnesium salts. So, but here is problem. So aluminum salts. See here, what are the examples I see in the first slide itself? Systemic antacids include sodium bicarbonate, sodium citrate, Non-systemic local antacids include magnesium salts like magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, as well as calcium carbonate. So we are preferring majorly non-systemic antacids. So majorly aluminum and magnesium salts. But the problem here is aluminum salts, majorly aluminum hydroxide gel produces constipation as a side effect. The magnesium salts like magnesium hydroxide, milk of magnesia, magnesium trisilicate, they produce diarrhea, laxation as a side effect. That's why if you see aluminum and magnesium salts always used in the combination. This is very important. If you see any marketed antacid preparation which consists of both aluminum and magnesium salts, the reason behind is aluminum salts produce constipation and magnesium salts produce diarrhea. Henceforth, the commercial antacid preparation, if you see, everything will consist of both aluminum and magnesium antacids. And if you see the combined antacid called as megalrate, so this megalrate is another antacid which is a combination of aluminum and magnesium salts and which is having both aluminum hydroxide and magnesium hydroxide. From the name itself, you can see megalrate. So Ma, magnesium, aluminum, hydroxide. If you see the representation here once again, so antacids, if you take, so they will neutralize the acid here. See, if you take sodium bicarbonate, which are systemic, see likewise, the systemic antacids will get absorbed. If they get absorbed, they produce systemic alkalosis, bicarbonate and C, basic. They produce. That's why systemic antacids are not preferred because of systemic alkalosis. See here, magnesium has laxative effects, aluminum causes constipation. Hence, aluminum and magnesium are used in combination. So one time coming to the ulcer protectives, from the name itself, ulcer protectives means these agents protect the ulcers. Suppose if any person is having ulcers already, if any person is having wounds, lesions already, these agents what they will do, they form a layer, they form a coat on the ulcers, and they will protect the ulcers from direct exposure to acid. These agents will form a layer on the ulcers, coat the ulcers, and they will protect the ulcers from direct exposure to acid or some other irritants. That's why they're called as ulcer protective agents. So example for this is sucralfate, nothing but sulfated sucrose. So I mentioned here, so ulcer protectives like sucralfate. Another one is bismuth subcitrate. Another example for is ulcer healing drugs. So coming to this point, ulcer healing drugs, so they heal the ulcers directly. If the drugs that directly heal the ulcers formed in the GAT. So one such beautiful example is carboxylant sodium. But this carboxylant sodium is obtained from the natural source, plant source called as Glycyrrhiza glabra, nothing but licorice. Carboxylant sodium obtained from the natural source, plant source, Glycyrrhiza glabra called as licorice. How it is having ulcer healing property? It is a natural source, plant source. It is having more lignin content. I think you have studied it on pharmacognosy, licorice plant, Glycyrrhiza plant, which is having saponin glycosides. Apart from saponin glycosides, some lignins, so many principles are there. These lignins and saponins will have wound healing property actually. Because of this wound healing property, they will also heal the ulcers. So got my point. If you see the ancient times, the very olden times, if any person is having some wounds, some rishis and all, they will apply some leaves on the wound that will heal the ulcers. The reason behind is what? The chemical constituents present in the leaves will have wound healing property. Likewise, this is the natural source. These contents have wound healing property. That's what I told. Ulcers are nothing but wounds. Ulcers are nothing but injuries, but taken place in the parts of GAT. Our normal wounds are external wounds. These ulcers are internal wounds. These internal wounds take place in the parts of GAT, majorly in the stomach or in the duodenum. That wounds, ulcers in the stomach called as gastric ulcers. That ulcers in the duodenum called as duodenal ulcers. So finally, if a ulcer is caused by the microbial contamination with Helicobacter pylori, we are using the drugs called as anti-Helicobacter pylori drugs. So usually this Helicobacter pylori is a gram-negative bacteria. So we are using the drugs like antibacterials and antiprotozoals. Like your amoxicillin, clarithromycin, azithromycin, some of the antiprotozoals like metronidazole, tinidazole. So this is it. We completed about peptic ulcer condition. With this, we completed about the first disorder, peptic ulcer. First class of drugs, anti-ulcer drugs. So coming to the another rarest condition, that is drugs for achlorhydria. So please try to understand the another rarest condition. It is not generally observed. So usually ulcer is a very common one. Achlorhydria is very, very less common one. So achlorhydria means I told you already. So from the name itself, we can understand easily. Rare condition, absence of HCl secretion, nothing but decreased acid secretion. Got my point? Achlorhydria means absence of acid secretion or decreased acid secretion. This is very, very, very rarely observed condition. So got my point? So most common condition is peptic ulcer. The very rarest condition is your achlorhydria. So where we observe, in which individuals we observe this achlorhydria is, so majorly seen in the children till 3 years of age. So got my point? Achlorhydria is seen in the children below 3 years of age. So after the birth, the infants, the children may not have good acid secretion. So that's why this achlorhydria condition is observed. So that's why if you see less than 3 years of babies, will have frequent indigestion, will have frequent vomiting and infections. That's why if you see the 1 year less babies, we will give very soft food, we'll give liquid food. So why we are giving liquid food? First we'll start with mother's milk, then we'll go for liquid food, then we go for semi-solid, then we go for solid. The reason behind is there is no acid, equal to the adults in case of less than 1 year babies. So this acid secretion reaches to the adult level at 3 years of age. That's why at 3 years of age we'll start input of solid food and protein food. And the major drugs used for this achlorhydria, and generally this is a physiological variable for children. We are not going to use any drugs. So up to 3 years we have to wait. After 3 years automatically acid secretion will increase. Persons will have normal digestion. But suppose if any adults are having achlorhydria condition, it is very rarest, not observed usually. If any adults are having achlorhydria condition, we can use the drugs called as cholinergics like carbachol and bethanacol. So we use anticholinergics for ulcers. We discussed yesterday acetylcholine. By acting through M1 and M3 receptors, the acetylcholine increases acid secretion. So for ulcer we are using anticholinergics. For achlorhydria we are using cholinergics like carbachol and bethanacol. Got it? So move on to the another topic in GIT, that is emetics and antiemetics. So with this we covered and completed anti-ulcer drugs, achlorhydria. So I talked about first difference between diseases and disorders, normal function of GIT, disorders of GIT, drugs acting on GIT, where in detail discussed about anti-ulcer drugs and drugs for achlorhydria. So move on to the next topic, that is emetics and antiemetics. So we all know that emetics are the agents which produce nausea and vomiting. Am I right? First, we move on to the emetics. Emetics are the agents which produce nausea and vomiting. And the only use of emetics is in the treatment of poisoning. Yes or no? So emetics which induce nausea and vomiting, the only application of emetics in pharmacy is in the treatment of poisoning. But they have some limitations. Am I right? But emetics will have some limitations. They are not suitable and they are not used in all the conditions. Emetics have some limitations and they are not suitable in the following conditions. So when the emetics are not used, in which type of poisoning conditions? See, apart from the treatment of poisoning, emetics doesn't have any application. Am I right? Emetics are the agents which induce nausea and vomiting. They are helpful to remove the poison from the body in the form of vomiting. But what I'm telling is, Emetics once again will have some limitations. Once again, we cannot use emetics for all types of poisoning conditions. In which cases we are not supposed to use emetics is in which type of poisoning conditions? I'm saying that. In which type of poisoning conditions emetics are not helpful is the first is if the patient is unconscious. Am I right? Emetics are not helpful if the person is unconscious. Next, emetics are not helpful if the poison is already observed. This is most important point. If the poison is already observed, means if the poison already enters into systemic circulation, we cannot use emetics because emetics will remove only unabsorbed, undigested substance which is present in the stomach. Yes or no? Once it is getting absorbed, once it enters into systemic circulation, it will not come back. It will not come back. We cannot get it back. So we are using emetics only when the poison is not absorbed. Because we know that sometimes if you vomit, what you tell that what is the reason for vomiting? Because food is not digested. Because of undigestion, indigestion, I'm having vomiting. So when there is no digestion, when there is no absorption only, vomiting is possible. The vomit is absorbed only which is not absorbed. So if the poison is already absorbed, it already entered into blood, we cannot get it back in the form of vomiting. But how will you come to know whether poison is absorbed or not, whether I have to use emetics or not is? That depends upon the time. That's why if any person taken poison, within 30 minutes, if you take him to the hospital, we should use emetics. But if the person taken poison some around 2 hours back, after 2 hours of taking poison, if you take the person to the hospital, there is no use of giving emetics because poison already getting absorbed, already started its action. So that is the reason physician will ask at what time the incident was happened, how long back the person taken the poison. The reason behind is to whether to give emetics or not. Next is what? If the poison is strong acid, strong base, or corrosive. Because if you use emetics for this type, which will cause a severe damage to the esophagus. Next is if the poison is detergents or petroleum products, because which will aspirate into lungs. And finally, if the poison substance ingested likely to cause rapid onset of drowsiness or seizures. So in all these type of specific conditions, we are not going to use emetics for the treatment of poisoning conditions. If the person is unconscious, if the poison is already absorbed, if the poison is very strong acid, strong base, corrosive, because it causes damage to esophagus, if the poison is some detergent or petroleum, which will aspirate into lungs, and substance ingested are likely to cause rapid onset of drowsiness or seizures. So what are the examples of emetics are? The good examples of emetics are apomorphine, ipecac, mustard, and salt powder. The examples of emetics are apomorphine, ipecac. As you know that Cipalis ipecac in the pharmacokinetics you studied. The active constituent there is emetic, mustard, as well as salt water. These are all the examples of emetics. So move on to the another important topic, antiemetics. So from the definition itself, we can understand antiemetics are the agents which will stop or prevent the occurrence of nausea and vomiting. These are all the drugs which will prevent or stop the occurrence of nausea and vomiting. So where we are going to use antiemetics is antiemetics are going to helpful where or wherever the conditions where we have vomiting. So what are the conditions associated with vomiting is I listed out the conditions where we observe vomiting majorly as a problem is, so one is a motion sickness. So we know that vomiting during journey or motion. So vomiting during journey conditions due to motion is called as motion sickness. Second is vomiting during pregnancy. So vomiting in the pregnant woman in the morning conditions is called as morning sickness. And some of the drugs will produce vomiting as a side effect, like levodopa. And anti-cancer drugs radiation therapy. As you know that anti-cancer drugs radiation therapy are associated with severe vomiting. And some of the conditions like migraine Even in the migraine also we have a severe vomiting. And because of a normal general conditions like excessive eating, excessive drinking, food poisoning, bad smell, bad odor. So these are all the conditions associated with vomiting. Where we have vomiting as a problem is during the journey conditions called as motion sickness, during pregnancy in the morning conditions called as morning sickness, when the person is on treatment with levodopa, when the person is on treatment with anti-cancer drugs, radiation therapy, when the person is suffering from migraine, when a person taken excess food or excess water or excess any drink, bad smell, bad odor, food poisoning. These are all the conditions where we observe vomiting, and these are all the conditions where we require the usage of antiemetics majorly. See, before going to see these antiemetics mechanisms examples, now we'll see the pathogenesis of vomiting. How exactly this vomiting is happening. If you know about this, how vomiting is happening, what is the reason for the vomiting, then you can easily understand about the mechanisms of antiemetics, everything examples under. So if you see the pathogenesis of vomiting, how and why it is happening. If you see here, the vomiting majorly occurs so because of the stimulation of vomiting center, which is called as emetic center. So try to understand there's a relationship very important. So vomiting occurs because of the stimulation of vomiting center. This vomiting center is otherwise called as emetic center. So this vomiting center is controlled by two centers. One is CTZ, another is NTS. CTZ means chemoreceptor trigger zone, which is located in CNS. NTS is nucleus tractus solitarius, which is located in GAT. So got my point? Vomiting occurs because of the stimulation of vomiting center. The vomiting center is once again controlled by two centers, CTZ and NTS. CTZ is located in CNS, NTS is located in GAT. So what is CTZ? Is the CTZ is having some receptors like D2, 5-HT3 and NK1 receptors. And the stimulation of these CTZ takes place because of the stimulation of any of these receptors. Am I right? CTZ, see, vomiting is because of stimulation of vomiting center. When the vomiting center will be stimulated due to stimulation of CTZ or due to stimulation of NTS. And what is the CTZ? When the stimulation of CTZ takes place is CTZ is having the receptors like D2, 5-HT3 and NK1. So the stimulation of this CTZ takes place because of the stimulation of any of these receptors. Same thing, stimulation of NTS located in GIT takes place because of excessive stimuli from stomach. When we have an excessive food intake, water intake, bad odor, bad smell, food poisoning, we have an excessive stimulation from stomach which will stimulate NTS, which stimulates the vomiting center. So what you understand here is always vomiting occurs because of the stimulation of vomiting center. This vomiting center stimulation takes place maybe because of the stimulation of CTZ or maybe because of the stimulation of NTS. And this stimulation of CTZ takes place because of the stimulation of some receptors like D2, 5-HT3 and NK1 receptors. And the stimulation of this NTS takes place because of the excessive stimulation from stomach. Now we'll see one by one. As you know that motion sickness, I told you just now, the vomiting during journey conditions, vomiting due to continuous motion. This condition is very likely to observe in the children the ages of 2 and 12 years. This motion sickness is majorly caused because of the disturbance in the vestibular system. As you know that the vestibular system is an apparatus which deals with the movement and balance. So which is trying to balance our signals inside the ear. So whenever because of motion, more vibrations will come, the vestibular system get disturbed, that lead to motion sickness. This motion sickness, vomiting during journey conditions majorly occurs because of the stimulation of muscarinic and H1 receptors in the vestibular apparatus, which further stimulates CTZ. So we know that CTZ is located in CNS. So vestibular apparatus is in the inner ear. We all know that there is a connection from ear to the brain. So this motion sickness, vomiting during journey conditions, occurs because of the stimulation of muscarinic and H1 receptors in the vestibular system in the inner ear, which further stimulates the CTC. So the other things. So what are the reason for other conditions? I told you morning sickness, vomiting during pregnancy in the morning conditions, levodopa, conditions like migraine. All these things will produce vomiting due to stimulation of D2 receptors present in CTZ. So anti-cancer drugs and radiation therapy produce vomiting due to stimulation of Hysteria receptors present in CTZ. So another NK1, neurokinin 1 receptors. So these get stimulated because of excessive release of substance P. So excessive release of substance P, which is observed due to chemotherapy, will cause the stimulation of NK1 receptors in CTZ causes vomiting. So stimulation of NTS takes place. So because of excessive stimulation from stomach, this is observed in case of excessive eating, drinking, and bad smell odor. So this is all the pathogenesis of vomiting. You please try to understand. So what I'm explaining you here is antiemetics are drugs which are used where we observe vomiting as a problem. That's clear, right? Antiemetics are drugs we are used to stop the vomiting, and we are used in the conditions wherever we have vomiting. What are the conditions where we observe vomiting is during journey conditions we have vomiting, that is called as motion sickness. During pregnancy we have vomiting, that is called as morning sickness. Some drugs will have vomiting as a side effects like levodopa, anti-cancer drugs, as well as in radiation therapy. Even in the migraine also people are having severe vomiting, and because of excessive eating, drinking, bad smell, bad odor, food poisoning, we have vomiting. So in all these conditions we have vomiting as a problem, and in all these conditions we are using antiemetics. So, but which antiemetics we have to use? What is the reason for vomiting? We explained here. The pathogenesis of vomiting, if you take, so vomiting always occurs because of stimulation of vomiting center. This vomiting center is controlled by two centers, CTZ and NTS. This stimulation of vomiting center takes place maybe because of stimulation of CTZ or because of stimulation of NTS. The stimulation of CTZ takes place because of some of the stimulation of some of the receptors present in the CTZ like D2, 5-3 and NK1. NTS will get stimulated because of excessive stimulation from stomach. So what are the things will stimulate these receptors is first, vomiting during journey motion sickness occurs because of the stimulation of muscarinic and H1 receptors in the vestibular apparatus, which further stimulates the receptors in CTZ, causes vomiting. And morning sickness, levodopa, migraine, where vomiting is because of the stimulation of D2 receptors in CTZ. Anti-cancer drugs and radiation therapy produce vomiting due to stimulation of Hysteria receptors in CTZ. So excessive release of substance P due to chemotherapy, that is because of the stimulation of NK1 receptors. And NTS will be stimulated when we have a more stimulation from stomach, when we are taking more food, more water, more any liquid, or because of bad smell, odor, food poisoning. So this is what I'm telling. There are the various reasons for vomiting. So stimulation of these receptors, what are things, everything I explained. So just have a look onto this for 2 to 4 minutes. Based on this, you only tell me what are the mechanisms you suggest for antiemetics. I'm telling you, explain you what is vomiting, what are the conditions associated with vomiting, how those conditions are producing vomiting, what are the receptors involved in vomiting, what is the pathogenesis of vomiting. By understanding of all these things, you just have a look onto this for 2 to 4 minutes, and on try to your own, on your paper, on your book, you try to write the mechanisms for antiemetics. By understanding of this, what is the mechanism for antiemetics? The antiemetics will have what type of mechanisms, you write it on the paper. I will come back just within 2 to 4 minutes. So yeah. So move on to the classification of antiemetics. So I hope so you have all written the mechanisms for these antiemetics. I hope the same mechanisms you may drawn, so you may develop. So based upon our earlier discussion on pathogenesis, so these are all the mechanisms and classification for the antiemetics. So here same thing. So motion sickness is because of the stimulation of muscarinic and H1 receptors, so that we are using anticholinergics and antihistamines. So muscarinic receptor blockers are called as anticholinergics. Antihistamines, especially H1 receptor blockers. Next. So we told the condition occurs because of the stimulation of D2 5-HT3 NK1. So that we are using the drugs called as D2 receptor blockers, Neuroleptics, 5-HT3 blockers, NK1 receptor blockers. And apart from that, we have some class of drugs called as gastroprokinetic agents and adjuvant antiemetics. So what about these drugs? We'll see exactly. So in which conditions these drugs are used and what are the examples, everything we'll see. The first one is anticholinergics. So examples are hyoscine, which is also called as copolamine, and also dicyclomine. So anticholinergics, the best example is hyoscine, also called as copolamine, and also dicyclomine. So this hyoscine available as transdermal patches, and these patches are applied behind the pinna. Pinna means what? Ear. So I told you these anticholinergics where we are using. See, muscarinic stimulation takes place because of motion sickness. In the motion sickness, muscarinic receptor stimulation takes place in the vestibular system. So that these anticholinergic patches, hyoscine patches, applied behind the pinna in the ear. Coming to the antihistamines, H1 blockers. So what are those? Promethazine, diphenhydramine, dimenhydrinate, cyclizine. So these are all examples. So all these anticholinergics and antihistamines, they are exclusively used for the treatment of motion sickness. Just now I told you, right? So this is very important. If any person is having vomiting during journey, the preferred antiemetics or the antiemetics to be used are anticholinergics and antihistamines, and they should be taken at least 1 hour before the commencement of journey. And partially they are also effective in morning sickness. So coming to the D2 receptor blockers, neuroleptics. They are majorly used to treat morning sickness, vomiting in the pregnancy, as we discussed already, right? What are the conditions? What are the conditions produce vomiting due to stimulation of D2 receptors? We discussed same thing. They are used to treat morning sickness, levodopa-induced vomiting, migraine-induced vomiting. So examples are chlorpromazine, haloperidol. But only thing is they are blocking D2 receptors so that they are producing extrapyramidal side effects like Parkinsonism-like side effects. So next, 5-HT3 blockers. We know that the 5-HT3 blockers are used to treat anti-cancer drug-induced vomiting and radiation therapy-induced vomiting. They are very, very important. Examples are ondansetron, granisetron. See here what happened, some of the representation. So if you take anti-cancer drugs, cytotoxic drugs, so these anti-cancer drugs, we know, they not only kill the cancer cells, they also kill the normal cells. So because of taking anti-cancer drugs, they will damage the enterochromaffin cells present in the GAT, normal cells of GAT. The damage to the normal cells of GAT causes excessive release of 5-HT, which stimulates the CTZ and produces vomiting. So as well, I told you, NK1 receptor blockers, so which are used when there is an excessive release of substance P, which is observed in case of chemotherapy, as well as in case of injuries. The best example of NK1 receptor blocker is aprepitant. Finally, gastroprokinetic agents. This is a very simple mechanism. So what these gastroprokinetic agents do is simply, they increase the movement of gastroprokinetic from the name itself. Kinetic means motility movement. Pro means promote, increase. Gastro means GIT. These are all the drugs which increase the motility of the GIT. Because of increasing the motility of GIT, they immediately causes the movement of things from stomach to the intestine. They increase the motility of GIT. They causes fast passage of contents from stomach to the intestine. So as a result, what happened? The things are moving immediately from stomach to intestine. So as a result, the things will not present in stomach for a long time. So hence there is no scope for vomiting. I already told you the vomiting is possible when the things are present in stomach. Once they cross the stomach, once they undergo absorption from small intestine, once they enter into systemic circulation, it will not come back. The vomiting is possible only when it is retained in the stomach. So gastroprokinetics causing the increasing the motility of GAT so that it immediately passes all the food contents from stomach to intestine so that there is no scope for the vomiting. This is the simplest mechanism what they are doing. How they are increasing the motility of GAT is by stimulating the 5-HT4 receptors in the GAT, which causes the release of acetylcholine. So this is a mind trick plexus mechanism. You try to understand the gastroprokinetics act by increasing the release of acetylcholine. Yesterday I told you acetylcholine increases the motility of GAT through M3 receptors. Clear? So the gastroprokinetics causes the release of acetylcholine, which increases the motility of GAT. Don't confuse that. In first class anticholinergics, their anticholinergics are blocking the muscarinic receptors in the vestibular apparatus, in the ear, in the CTZ. Site of action is different. Here, these drugs cause the release of acetylcholine in the GAT region, in the local region, which increases motility of GAT. So what are those drugs? Are metoclopramide, domperidone, cisapride, mosapride, tegaserine. Out of all these first two drugs, we also have D2 receptor blockade mechanism. Apart from gastroprokinetic mechanism, they also have D2 blockade mechanism. And finally, adjuvant antiemetics, so which don't have antiemetic property, but they increase the activity of other antiemetics. From the name itself, adjuvant, as such as it is, they don't have any antiemetic property, but they increase the activity of other antiemetics. So which include benzodiazepines, corticosteroids, cannabinoids. So cannabis, we know that more hallucination side effects will be there, CNS property. So that we are using the very safe drugs like dronabinol and nabilone. So with this, we have completed this emetics and antiemetics also. So I'm repeating just for 1 minute to 2 minutes. So emetics are the agents used for vomiting. They are used to remove the poison from the body. But emetics have some limitations like if the person is unconscious, we should not use. Emetics are not useful in these conditions like person is unconscious, poison is already absorbed. If the poison is strong acid or strong base or corrosive, if the poison is detergent, or if the poison likely to cause some seizures. So what are the examples of emetics are apomorphine, emetin, mustard, and salt water. Antiemetics are used to stop the vomiting. In which conditions we observe vomiting is during journey called as motion sickness, during pregnancy called as morning sickness, during some drug therapy called levodopa anti-cancer drugs, during radiation therapy, during migraine, and because of excessive eating, drinking, and because of bad smell odor. So different conditions produce vomiting because of different reasons. The motion sickness, vomiting during journey is because of muscarinic and H1 receptor stimulation in vestibular apparatus in the ear in the CTZ. So next, levodopa, morning sickness, migraine produce vomiting due to stimulation of D2 receptors. Anti-cancer drugs, radiation therapy produce vomiting due to stimulation of 5-HT3 receptors. Excessive release of substance P during chemotherapy produces vomiting due to stimulation of NK1 receptors. Based on this, we developed the mechanisms. So anticholinergics and antihistamines are majorly for motion sickness. D2 blockers are for morning sickness and levodopa-induced vomiting, migraine-induced vomiting. 5-HT3 blockers for anti-cancer drug and radiation therapy-induced vomiting. NK1 receptor blockers for substance P-induced vomiting. Gastroprokinetics for the general mechanism. Adjuvant antiemetics, which increase the activity of other antiemetics. So for your exercise point of view, I given one representation here. On your paper, you just write what are the answers for this. So I'm telling that these are all the different conditions. These are all the different antiemetics. So you tell me the which condition we are using which class of drug, which type of drug. So on your paper, you write for one, motion sickness, which drug is used? A, B, C like this. Second, levodopa-induced vomiting, which drug is used? A, B, C like this. You match these things. 1, 2, 3, 4, 5, 6. You write it on a paper. For first, what is the drug? For two, what is the drug? A, B, C like this. Match them. Likewise, 1B like this, something you can write it. You write it. Whether you are getting or not, we'll see. You just assess yourself selfly. Yeah, you see one by one. For motion sickness, so we told for motion sickness we are using anticholinergics and antihistamines. So hyoscine is used. So levodopa induced vomiting, D2 blocker, haloperidol is used. Chemotherapy induced vomiting, 5-3 blockers like ondansetron. Substance P induced vomiting, NK1 receptor blocker like aprepitant. Gastroprokinetic with D2 receptor blockade property having by metoclopramide. Adjuvant antiemetic is cannabinoids. So this is the thing. So BEFCAD. So coming to the next class of drugs on GAT, so which is antidiarrheal agents. It is a very small condition. We all know that. So antidiarrheal agents means used for the treatment of diarrhea. So we all know that diarrhea is characterized by increase in the frequency of passage of stools. If you see this diarrhea, I think it's a very common condition. Most of the people are suffering more times. Most of the times diarrhea occurs because of contamination with microorganisms considered as a disease, and very few cases it occurs because of increased peristaltic movement of GAT called as a disorder. So mostly diarrhea is a disease. Mostly it occurs because of contamination with microorganisms, and rarely it is a disorder occurs due to increased peristaltic movement of GAT. See, so how will you identify or which microorganism is causing diarrhea? How will you identify is? You'll see. So most of the times diarrhea is a disease caused by contamination with microorganisms. What are the related conditions to diarrhea is if you have more water in the stools, that diarrhea is called as watery or loose stools, which indicates bacterial infection. So if you have blood in the stools, which is called as dysentery, that is caused by Shigella. If you have pus in the stools, that is called as amoebiasis, which is caused by Entamoeba histolytica. If you have severe vomiting with diarrhea, which is observed in case of cholera, caused by Vibrio cholera. So fever with diarrhea observed in case of Salmonella infection. Traveler's diarrhea. So diarrhea during traveling conditions. So during traveling conditions, we are taking water, food from outside, which is contaminated with microorganisms. That is mostly with E. coli. This is all the various microorganisms mostly causing diarrhea. You know that loose motions, loose stools, watery stools, which is majorly because of bacteria. If you have a blood in the stools called as dysentery caused by Shigella, if you have a pus, white debris in the stools called as amoebiasis caused by Entamoeba histolytica, vomiting with diarrhea because of cholera, Vibrio cholera, fever with diarrhea called as salmonella infection, traveler's diarrhea, diarrhea during traveling because of taking water, food from outside. Not only traveler's diarrhea, whenever you take food from outside, from neighbors or from relatives, sometimes you have diarrhea. That mostly the food is contaminated with the organism called as E. coli. So most of the times diarrhea is caused by contamination. The very commonest microorganism is E. coli, Escherichia coli. So first, the concept of treating diarrhea is, so why we should treat the diarrhea is, as we all know that if you have a diarrhea, there is a huge loss of water and electrolytes from the body. The severe loss of water and electrolytes from the body leads to dehydration. Sometimes dehydration leads to death also. So that the dehydration will be corrected by rehydration. Depending upon the emergency, we'll go for oral or IV. If the person condition is normal, we'll go for ORS, oral rehydration salts, oral route. If the person is very emergency, we'll go for rehydration by IV route. So usually composition includes all. We'll go for replacement of electrolytes, some buffers, some nutrients as well as fluids. If you come into the treatment of diarrhea is two types. So one is going for specific antimicrobial drugs, another is non-specific antidiarrheal drugs. So in the beginning, I told you the diarrhea mostly is a disease caused by contamination with microorganisms. Such a case, we are using the drugs called as specific antimicrobial agents. And few cases, sometimes diarrhea is a disorder due to increased peristaltic movement of GIT. Such case, we are using non-specific antidiarrheal agents. So what are the specific antimicrobial drugs we are using is, so if you see these microorganisms, so this is bacteria, Shigella is a bacteria, Vibrio cholera is a bacteria, Salmonella is a bacteria, E. coli is a bacteria. So mostly it is caused by bacteria, and Entamoeba histolytica is a protozoa. So that we are using antibacterials and antiprotozoals. Most antibacterials used are fluoroquinolones like ciprofloxacin, norfloxacin, gefloxacin, levofloxacin, tetracyclines, and cotrimoxazole. And antiprotozoals like metronidazole and tinidazole. That's if you see in the market also, where you're having a combination of ciprofloxacin with metronidazole, norfloxacin with metronidazole. The reason behind is the diarrhea is because of bacteria and protozoa will happen. So coming to the non-specific antidiarrheal drugs, which are used when the diarrhea is caused by other than microbial contamination as a disorder due to increased peristaltic movement of GIT. So which include two classes, anti-secretory drugs and anti-motility drugs. So anti-secretory drugs include the first drug sulfasalazine. The sulfasalazine, by the action of the enzyme 5-azoreductase, converted to 5-aminosalicylic acid and sulfapyridine. This 5-aminosalicylic acid, it is a salicylic acid. As you know that aspirin, acetyl salicylic acid, NSAIDs, inhibit COX, right? 5-aminosalicylic acid inhibits COX. If inhibit COX, inhibits prostaglandins. Decrease in prostaglandins inhibit the secretions. I told you prostaglandins increase all secretions of mucus, bicarbonate, everything, and decreases the motility. But here is important point, that it inhibits COX in the colon, large intestine. How will you get the action in the large intestine is, actually if you take sulfasalazine, the sulfasalazine drug is not absorbed. It is unabsorbed drug. As I told you, all unabsorbed things will reach to the large intestine. In the large intestine, we have an enzyme azoreductase converted to 5-aminosalicylic acid. This drug inhibits COX in the large intestine, so inhibits secretions in the large intestine and inhibits the passage of stools. Clear? Sulfasalazine is not absorbed, reaches to the large intestine. In the large intestine, we have this enzyme converted to 5-aminosalicylic acid, inhibits COX enzyme in the colon, inhibits prostaglandins, inhibits secretions and motility. The official name given to 5-aminosalicylic acid is mesalamine. Acetyl salicylic acid is called as aspirin, like that 5-aminosalicylic acid is called as mesalamine mesalazine. And coming to the anti-motility drugs, from the name itself, which decrease the motility of GIT. So major drugs used are opioids, morphine, loperamide, diphenoxylate. All these drugs act through the opioid receptors present on the large intestine colon. So morphine is not used because of more CNS depression addiction property. We are mainly preferring loperamide diphenoxylate. And anticholinergics, we know that. Yesterday we discussed acetylcholine increases motility of GIT. So anticholinergics decreases motility of GIT. If you decrease the motility of GIT, you decrease the passage of stools. So they are used as antidiarrheals. And finally, drugs used for constipation, the last topic in the GIT. Drugs used for constipation. So we all know that constipation is what? Decrease in the passage of stools or difficulty in the passage of stools. Opposite to diarrhea. So usually constipation is a not frequently observed condition. Constipation is majorly seen in the adults, elders. If you see, constipation is very common above 50 years, 60 years of public, because when the age increases, the motility of GIT decreases. As you know that in the age increases, the functioning of every system becomes less. So when the age increases, the functioning of GIT, the movement of GIT, the motility of GIT becomes reduced. Hence, it is a common problem in the adults, elders, constipation. So the drugs used for constipation called as different terminologies we are using: aperients, laxatives, purgatives, cathartics. Aperients are very milder, laxatives are milder, purgatives are stronger, cathartics are very strong. Means all are having same mechanism of action, same mode of action. Examples are also same, but the different in the intensity of action. The same agent, if you use in very less doses, it is an aperient. If you increase the dose, laxative. If you increase the dose, purgative. If you increase the dose, cathartic. Examples are same, mechanisms are same, but intensity of action is different. So if you see classification of laxatives, that's what. This is not only a classification for laxatives, classification for purgatives, cathartics, everything. All these drugs are classified into 4 types, which include one is irritant or stimulant laxatives, bulk forming laxatives, osmotic or saline laxatives, surfactant laxatives or stool softeners. So one by one you see. So irritant or stimulant laxatives. From the name itself, you can see here stimulant. They increase the peristaltic movement of GAT. They act by increasing prostaglandins. They act by increasing secretions. So which called as stimulant laxatives. Stimulant by means of stimulant mechanism. They increase the motility of GAT. They increase the prostaglandins. They increase the secretions. Why they are called as irritant laxatives is all these agents are highly irritating in the stomach. The best examples are bisacodyl belong to diphenylmethyls. Senna cascara, I think you have studied in the pharmacognosy, anthraquinoglycosides. Castor oil, which is a fixed oil, all are irritant laxatives. I think we all know that if you take castor oil, you will get free motion. You can treat constipation. But can you suggest to take castor oil for someone for treating constipation? No, because of the high irritation property. So coming to the next, bulk forming laxatives. From the name itself, you can understand bulk forming laxatives means these agents are not digested. If they are not digested and they are not absorbed. So these agents are not digested as well as these agents are not absorbed. So due to indigestion, all unabsorbed bulky material will reach to the large intestine. Am I right? When there is no digestion, there is no absorption. Because of no digestion, no decrease in the particle size. So all that bulky material will reach to the large intestine. Because of bulkiness in the large intestine, it creates some bulkiness, so it causes free passage of stools. So examples are ispagula, called as isabgol, psyllium plantago, and some of the fiber food. If you take fiber food, if you take some ispagulas, psyllium, all these bulky materials are unabsorbed, undigested. All the bulkiness reaches to the large intestine. It is creating bulkiness in the large intestine. It automatically causes the passage of stools. So coming to the osmotic laxatives, which also known as and which also called as saline laxatives. Same thing. These agents are also not absorbed, and osmosis mechanism they have. Osmosis mechanism means they have the retention of water property. So now what happened? They are not absorbed. Something is unabsorbed. I told you in the beginning, all unabsorbed substances will reach large intestine. And because of the retention of water, the compounds are swelled. So due to retention of swelling compounds in the large intestine, that creates bulkiness once again. That causes free passage of stools. All the osmotic laxatives are not absorbed. They have osmosis mechanism. They have the retention of water. So all these unabsorbed swelled compounds reach the large intestine, which will create once again bulkiness, causes free passage of stools. The examples are like this. So magnesium sulfate, magnesium hydroxide, sodium sulfate, sodium potassium tartrate, polyethylene glycol, glycerin, lactulose. So examples like your Epsom salt, magnesium sulfate called as Epsom salt, magnesium hydroxide called as milk of magnesia, sodium sulfate called as Glaber's salt, sodium potassium tartrate called as Rochely salt. And these are some of the brands. So Dulcolax is Bisacodyl, is an irritant, stimulant laxative. See here they written stimulant laxative, OTC products, over-the-counter products. Miralax, polyethylene glycol, osmotic saline laxative. See here they mention osmotic laxative. Finally, coming to this last one, surfactant laxatives. These surfactant laxatives, also called as stool softeners. The surfactant laxatives, also called as stool softeners. So here, what happened is, from the name itself, stool softeners are which soften the stools. They are used when conditions called as hardening of stools. See, I told you in the beginning, some persons are having difficulty in the passage of stools. That difficulty in the passage of stools is because of more hardening of stools. There is more reabsorption of water. So because of more reabsorption of water, the stools will become hardened. The persons are feeling difficulty in the passage of stools. Such a case, we are using these drugs majorly. So what are these stool softeners is, all these agents are surfactants. So what are surfactants? We all know that. So these agents are surfactants which reduce the interfacial tension. So because of reducing interfacial tension, they increase the water incorporation into the stools and they soften the stools. Surfactants reduce surface tension, interfacial tension. As you know that if you reduce the interfacial tension between miscible and immiscible things, the water incorporation will be increases. Due to incorporation of water, they soften the stools. That's why called as stool softeners. They are having surfactant mechanism nature, which called as docusets. The full form of docusets is dioctyl sodium sulfosuccinate, which is anionic surfactants, and also mineral oils we are using. Here, this is what the surfactant laxatives. So this is what the four types of laxatives you see here. The irritant or stimulant laxatives. Stimulant means they increase the peristaltic movement of GIT, they increase the prostaglandins, they increase the secretions, and they are highly irritating in stomach. Examples are bisacodyl, anthraquinones, fixed oils like castor oil. Bulk forming laxatives, they are not digested, they are not absorbed. All undigested, unabsorbed bulkiness will reach large intestine, which will create bulkiness, causes free passage of stools. Like your fiber food, ispagula, psyllium. Osmotic saline, they are not absorbed, they have the osmosis property, retention of water, swelling nature will be there. All swelling compounds reach large intestine, causes retention, free passage of stools. Stool softeners, they soften the stools, they increase the water incorporation into stools by surfactant nature by reducing interfacial tension. Those are docusets, dioctyl sodium sulfosuccinate. So this is the kind of OTC drugs called as laxatives used for the treatment of constipation. With this, we have covered and completed one of the topic in pharmacology and one of the important topic in pharmacology and simplest topic in pharmacology, that is drugs acting on the GAT. Just all of you be attentive. Just within 2 to 5 minutes, I will explain you everything from the beginning to here, what I discussed so far. So that will give you some better clarity for you. So what discussed. And I will show you some one video regarding our discussion, which will once again will give you more clarity about the mechanisms and the discussion what we made here. So 2 minutes. So 1 minute, I will explain you everything. So be attentive, all of you active. See, what I'm telling here is, so today's topic is drugs acting on GAT. First, we should know the difference between two conditions called as diseases and disorders. So diseases are caused by harmful pathogenic microorganisms. Disorders are due to altered abnormal functioning of body system. Our human body is made up of several systems. Every system has certain functions. When the function of the systems get altered, that lead to disorders, so that we are using drugs. If we come into our system today, GIT, gastrointestinal tract, first, what is the normal function? What are the disorders? Then what are the drugs? We'll see. First, what is the normal function of GIT is? The GIT is having three major parts: stomach, small intestine, large intestine. So stomach is the area for digestion because of the release of acid. Small intestine is the area for absorption from which the food as well as drugs will enter into systemic circulation, undergo absorption. All unabsorbed, all unabsorbed materials are reaching large intestine. All these waste compounds are eliminated through stools, fecal matter. That elimination through fecal stools is called as defecation. Coming to the disorders, the excessive secretion of acid in the stomach called as peptic ulcer, that majorly occurs because of disturbance in the homeostasis between aggressive factors and defensive factors. Henceforth, for aggressive factors, we are using antagonists, and for defensive factors, we are using agonists. The aggressive factors which increase acid secretion are acetylcholine, histamine, gastrin, so that we are using anticholinergics, antihistamines, gastrin antagonists, proton pump inhibitors. Then microorganism causing ulcers is Helicobacter pylori. We are using anti-Helicobacter pylori drugs. And defensive factors are prostaglandin, so we are using prostaglandin analogs. And apart from that, we are using some drugs which neutralize the acid called as antacids. And apart from these two classes, we are using ulcer protectives which protect the ulcers from direct exposure to acid. And finally, ulcer healing drugs. So next is achlorhydria, absence of acid secretion, decrease in acid secretion only seen in the less than 3-year babies. As the age increases, acid secretion will reach, no need of drugs. But if achlorhydria is there in the adults, we are going for cholinergics like carbachol, bethanacol. And coming to emetics and antiemetics, the only use of emetics is to remove poison from the body. And emetics are not suitable when the poison is already absorbed, when the person is unconscious, when the poison taken is acid, base, or corrosive substance, when the poison ingested is some detergent or detergent type of properties. And antiemetics are used whenever you have vomiting. Some of the vomiting related conditions are motion sickness during journey, morning sickness during pregnancy, during drug therapy like levodopa therapy and anti-cancer therapy, radiation therapy, when the person is suffering from migraine, and when you have excess eating, excess drinking, and bad smell, bad odor, food poisoning. So different conditions produce vomiting because of different reasons. As per that, we are using different classes of antiemetics. Anticholinergics and antihistamines used for motion sickness. D2 receptor blockers, neuroleptics for levodopa-induced vomiting, morning sickness, and migraine-induced vomiting. 5-HT3 blockers for anti-cancer and radiation therapy-induced vomiting. Gastroprokinetic agents, simple mechanism which increase the peristaltic movement of GIT. They cause the fast passage of contents from stomach to intestine. And coming to the antidiarrheals, so therefore diarrhea, mostly diarrhea is because of contamination with microorganisms, so that we are using antimicrobials, especially antibacterials and antiprotozoals. And if the diarrhea is a disorder, suppose because of increased peristaltic movement of GIT, we are using the drugs called as anti-secretory drugs, which decrease the secretions, which decrease the fluid, which bicarbonate ions and all. So one such drug is sulfasalazine. And we are using anti-motility drugs which decrease the motility of GIT, anticholinergics and opiates. So opiates which are having less CNS depression addiction property are more commonly used, like loperamide, diphenoxylate. Coming to the drugs for constipation, laxatives, 4 classes of laxatives like irritant laxatives, stimulant laxatives, which increase the peristaltic movement of GIT. Bulk forming laxatives, they are not digested, not absorbed, all will get accumulated in large intestine. Osmotic laxatives, they are not absorbed, have osmosis property, retention of water property. Finally, stool softeners, they soften the stools, increase the water incorporation. They are surfactants, reduce the interfacial tension. So this is the brief revision about drugs acting on the GIT. So once again, I'm telling that, so myself, Dr. Nagarjuna, I am the coordinator for GPAT cell in Raipur, Anantapu, and myself, and yesterday evening, pharmaceutics class taken by Venkatrao sir. Myself and Venkatrao sir both are coordinators and conducting the coaching for GPAT for pharmacy students in Hyderabad Academy and online GPAT Academy. And the details are, this is my contact number, this is my WhatsApp number, this is my mail ID. So yesterday, so many students asked for the PPT. I forwarded to the university mail. So soon they will update and they will keep it in the website. You can get the pharmacodynamics PPT from the website. So everything, whatever I discussed, all the PPT will forward to the university mail ID. So definitely university will keep in the website. You can download from that. So still, meanwhile, if you have any doubts, you just contact those WhatsApp numbers or to this mobile number also. So once again, I'm thanked to this AP government, JNTU Anantapur and JNTU Kakinada for giving this opportunity and for providing this platform to the students. And finally, I will show you one video which explain you the anti-ulcer drugs. All of you, please be watch it and be attentive. See here, all of you watch this, you can understand it. See here, the parietal cells release acid, which cause damage to the mucous layers of GAT and causes the formation of ulcers. See, like this, ulcers means wounds, injuries take place in the parts of GAT. See here. So some of the drugs they represented here, proton pump inhibitors, I told H plus K plus ATPase inhibited by these drugs. So these drugs will neutralize the, H2 blockers. See here. Antacids, which will neutralize this. So now you understand. So yesterday I discussed how the ligands will produce the pharmacological action. See, so what are the ligands here? Aggressive factors, defensive factors, acetylcholine, histamine, gastrin, prostaglandins. See, acetylcholine binds to these receptors, M1, M3, histamine H2, PGE2, gastrin CCK2. See here, acetylcholine, gastrin, calcium means what? IP3DAZ, means GQ type. These two are GQ type, so increases acid secretion. Histamine, GS type, stimulation of adenyl cyclase. Prostaglandins, GI, inhibition. That's why prostaglandins are defensive factors, inhibiting acid secretion because they are GI type. Histamine increases acid secretion because GS type. Acetylcholine, gastrin, GQ. GQ means I told IP3D is always stimulation, so increase acid secretion. So likewise, the antacids will work. So digestive H plus, the antacids if you take. So likewise, the antacids will work out. Neutralize the acid. Now understand? So because of this acid secretion, the excessive acid secretion, the ulcers are formed like this. See, they represent ulcers here. So this is ulcer. So what ulcer protectives are doing? They are protecting the layer around the ulcers. They are protecting layer around the ulcers that will protect ulcers from direct exposure to some other irritants and acids. So this, I mean to say that you can understand the anti-ulcer drugs. I mean the drugs acting on the GAT. So in well. So I hope you understand all this. So with this, we have completed all about these drugs acting on the GAT. So I hope whoever understand this topic, like this topic, so you please put like in the YouTube. And I hope with this, we completed pharmacodynamics and drugs acting on the GAT. So tomorrow we'll come with the new session. So that may be drugs acting on the cardiovascular system. So once again, so thanks to one and all for this opportunity and have a nice day. Thank you. Bye.